Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text.
Hello everyone, and welcome back to another edition of The Deep Dive. I'm your host, and today we're doing something a little bit different. We are going into the basement.
The basement.
Yeah, the plumbing. We're looking at the pipes, the reservoirs, and the valves that basically keep the human body from essentially poisoning itself. We are diving into Robbins and Coutran pathologic basis of disease, specifically Chapter 21, the lower urinary tract and male genital system.
Yeah. It's a chapter that students, they often gloss over it because they're so intensely focused on the glamour organs like the heart or the brain.
Right, the flashy stuff.
Exactly. But if you ignore this chapter, you miss some of the most mechanical, literally high-pressure pathology in the entire book.
And that's really our mission today. We are treating this deep dive as a last-minute lecture. So if you're a med student with boards tomorrow, or maybe a resident trying to survive pimping on rounds, or just someone who wants to know why their grandfather's waking up, 4 times a night to pee, this is for you. But we aren't just going to read the text to you. We're going to look at the why behind it all.
Right. We're going to follow the flow of urine, essentially, from the kidneys, down the ureters, into the bladder, and then out through the urethra and the male reproductive tract.
So let's set the scene anatomically first. The text really emphasizes that the pelvis is a crowded neighborhood.
Oh, it's extremely high-density housing down there. I mean, you have the bladder sitting right up against the rectum. In males, the prostate is wrapped around the urethra like a tight collar. In females, the uterus is pressing down right from above. Everything is just fighting for a tiny bit of space.
And this proximity, it's dangerous, right? It sounds like if one thing goes wrong, it's definitely going to affect the neighbors.
It creates this massive domino effect. Pathology in the pelvis is very rarely isolated. So if you have a tumor in the rectum, it could easily invade the anteriorly located bladder. Or if you have endometriosis in a female patient, those errant endometrial implants can scar down and actually constrict the ureters. But really, the most critical concept to keep in mind here is obstruction.
Obstruction. The plumbing analogy again?
Exactly. This entire system is designed for one-way flow. If you block that flow anywhere, like at the urethra, the prostate, the bladder, necker, the pressure doesn't just vanish into thin air. It reflects backward.
The text calls this retrograde damage, right?
Yeah. Think of it like a clogged sewer line in a house. If the main line out to the street is blocked, the backup happens upstream in your sinks and tubs. In the body, the bladder muscles thicken, they hypertrophy to fight the pressure.
Pushing harder against the blockage.
Right. And if they lose that battle, the ureters dilate to accommodate the backup. And eventually, all that hydrostatic pressure hits the kidneys.
Causing hydronephrosis.
Which is the death knell for the kidney. So a simple localized problem in the prostate, which is a male reproductive organ, can end up killing the kidneys, which are absolutely vital for life. It's all intimately connected.
Wow. And we also have to mention the specific geography of where these upper tubes sit. The retroperitoneum.
Yes. The space situated behind the peritoneal cavity. The ureters run right through this space on their way down. This is crucial because tumors or inflammatory fibrosis in that retroperitoneal space can entrap the ureters from the outside, like a vice grip.
So it's not a block inside the tube itself?
No, it's a stranglehold from the outside. The lumen is clean, but the pipe is being crushed.
Okay, let's officially start our journey at the top of this system, the ureters.
The muscular tubes connecting the renal pelvis of the kidney down to the bladder.
Now, Robbins mentions that congenital anomalies here are actually surprisingly common. Something like 2 or 3% of all autopsies show some sort of weirdness in the ureters.
Which is a huge number when you think about it. Imagine a room of 100 people. 2 or 3 of them have double ureters or split ureter, and they probably go their whole lives and don't even know it. Most of these are totally incidental.
Just plumbing quirks.
Exactly. Just anatomical variations that don't really affect the functional flow of urine.
But there is one anomaly that the book points out is definitely not just a quirk. The UPJ obstruction.
The ureteropelvic junction obstruction. Yes. This is extremely high yield for exams. If you remember nothing else about congenital ureter issues, remember this one.
This is the bottleneck we talked about.
Literally. It's the exact point where the wide renal pelvis, that funnel, collecting all the newly made urine from the kidney, narrows down to become the slender ureter tube. In a UPJ obstruction, that transition point is mechanically pinked.
So is it a physical kink, like a bent garden hose in the yard?
Sometimes it's a physical external compression, like an aberrant renal artery crossing over it, but very often it's microscopic. The actual smooth muscle bundles at that junction are developmentally disorganized.
Disorganized how?
They're chaotic. Or there's a localized excess of collagen deposition. So instead of a nice coordinated peristaltic wave pushing the bolus of urine down, the muscle just spasms or completely fails to contract. The urine just hits a functional wall.
And since the kidney above it keeps churning out urine nonstop, the pressure just builds and builds behind that wall.
Correct. And this actually presents very differently depending on who you are. If we're talking about infants and young children, it is the number one most common cause of hydronephrosis. And interestingly, it's usually little boys.
And often bilateral in those cases, right, affecting both kidneys.
In infants, bilateral presentation is fairly common, which is a true medical emergency because you risk permanently losing renal function on both sides before the child even grows up. But if this presents later in life, in an adult...
The text says the demographics completely flip. It becomes more common in women, and it's usually just on one side.
Exactly. Unilateral in adult women. It's a really strange demographic flip. But mechanically, whether it's an infant or an adult, the end result is the exact same. You get a swollen, pressure-damaged kidney entirely caused by a bad anatomical valve.
Moving on to tumors of the ureter. The text kind of implies these are pretty rare overall.
They are. Primary isolated tumors of the ureter are not something you see every day. You can see benign lesions like fibroepithelial polyps, which tend to mostly show up in children.
What are those made of?
They're basically composed of a loose, vascularized connective tissue core that's covered by normal-looking urothelium. They just kind of dangle in the lumen.
But if a ureteral tumor is malignant?
If it's malignant, it is almost always a urothelial carcinoma, completely mirroring what we see down below in the bladder.
Yeah.
In fact, if you look at figure 21.1 in the text, it beautifully shows a papillary urothelial carcinoma involving the ureter.
Right. The image shows this frond-like mass that just physically fills up the entire inside of the tube.
And because the ureter is such a remarkably narrow tube to begin with, a tumor there causes a severe obstruction really quickly. It doesn't have to go very big at all to cause a total clinical crisis.
Which naturally brings us to the broader category the book covers next. Obstructive lesions. The big why of hydroureter. Why is the tube blocked in the first place? Right.
We generally divide this into intrinsic and extrinsic causes. Intrinsic is the stuff physically inside the tube blocking the way.
So stones.
Calculi are the classic intrinsic cause,
right,
or fibrous strictures from old healed infections, or even blood clots from bleeding higher up in the kidney.
But the extrinsic causes, the outside forces, really highlight that crowded pelvic anatomy we were talking about earlier.
Oh, absolutely. Pregnancy is a massive physiologic extrinsic cause. It's a combination of the physiologic relaxation of the smooth muscle, thanks to all that circulating progesterone, combined with the literal physical pressure of the growing fetus right at the pelvic brim, pressing the ureters against the bone.
The book also mentions endometriosis here.
Yes, errant endometrial tissue can seed out near the ureters, bleed during the menstrual cycle, and cause progressive scarring and fibrosis that eventually chokes the tube. And of course, expanding tumors from other organs like the rectum, ovary, or uterus, pressing in aggressively from the outside.
There was one specific condition mentioned in this section that sounded quite intense: sclerosing retroperitoneal fibrosis.
This is a really fascinating, albeit rare condition. Imagine a fibrotic straitjacket. It's a proliferative inflammatory process that completely encases the retroperitoneal structures. It just wraps this dense, woody, fibrous tissue, mostly around the mid and lower portions of the ureters.
And what's the actual cause of that?
Well, for a long time, we just called it Ormond disease, or we labeled it idiopathic, which is just doctor speak for we have no idea. But recently, there's been a breakthrough. We found a strong connection to IgG4-related disease.
IgG4. This is that systemic autoimmune condition that seems to be popping up everywhere in pathology literature lately. Can you unpack that for the listener?
Absolutely. IgG4-related disease is a fascinating systemic fibroinflammatory condition. It's characterized by various tissues getting heavily infiltrated by specialized plasma cells that secrete IgG4 antibodies.
And what does that do to the tissue?
It leads to what we call store-form fibrosis, which means a mat-like or swirling pattern of scar tissue and obliterative phlebitis, where the veins get choked off. It can hit the pancreas, the salivary glands, the thyroid, and yes, the retroperitoneum.
So the dense fibrosis around the ureter in these patients is really just one local manifestation of a whole body immune problem.
Exactly. And recognizing it as an IgG4 issue is incredibly crucial because it often responds very well to systemic steroids, unlike normal, simple scar tissue, which doesn't care about steroids at all.
The text also mentions some drug associations for this fibrosis.
Yeah, historically, we see associations with certain drugs like ergot derivatives used for severe migraines and some beta blockers. But essentially, whatever the trigger, the body just lays down dense scar tissue that strangles the ureters from the outside.
Okay, let's follow the flow of urine down further into the reservoir itself, the urinary bladder.
The main holding tank.
Let's start with the congenital stuff here again. First up, diverticula.
Right. A diverticulum is essentially a pouch-like invagination of the bladder wall. Think of a weak spot in a bicycle tire inner tube bulging out under pressure. It can be congenital due to a focal failure of the normal muscle development in the fetus, but far more often, it is an acquired condition.
Acquired how? From what kind of pressure?
Usually due to chronic outflow obstruction, like enlarged prostate BPH in older men. The bladder muscle, the detrusor, has to push so incredibly hard to get urine past the enlarged prostate that the sheer internal hydrostatic pressure forces the inner mucosal lining to herniate right through the thicker muscle bundles.
So what's the clinical risk there? Is it just having a funny-shaped, lumpy bladder?
No. The real clinical risk is stasis. When you urinate, the main bladder empties, but the urine gets stuck inside that little pouch. It doesn't have the muscle to squeeze itself empty.
So it just sits there.
Right. And stagnant urine at body temperature is an absolute playground for bacteria, so you get recurrent, stubborn infections. Plus, stagnant urine allows minerals to precipitate out, so you get painful bladder stones forming right inside the diverticulum.
Then there's exstrophy. Figure 21.2 describes this condition, and honestly, it's a pretty harrowing image to visualize.
It really is. It's a profound developmental failure of the anterior abdominal wall. The bladder essentially forms wide open to the outside world. If you look at the newborn, you see exposed, beefy red, hyperemic bladder mucosa right on the surface of the infant's lower abdomen.
And this usually happens in conjunction with epispadias, right? A specific malformation of the penis.
Yes, they often go hand in hand. And aside from the immediate massive surgical challenge to reconstruct the anatomy, the long-term pathologic risk here is chronic irritation.
Because it's exposed.
Exactly. That incredibly delicate mucosa is constantly irritated by the outside environment, clothes, diapers, infections. And as we learn in pathology, chronic injury leads to metaplasia, the tissue-changing types to protect itself. And eventually, that carries a huge risk of developing adenocarcinoma later in life.
Got it. One more congenital anomaly for the bladder. The urachus.
The urachus.
Yeah.
This is the embryonic canal that originally connects the fetal bladder straight to the umbilicus, the belly button. Normally, before you're born, it's supposed to completely close up and fibrose into a solid cord called the median umbilical ligament.
But if it doesn't close...
If it stays entirely patent, you can have a complete fistula where urine actually visibly leaks out of the belly button.
That's incredibly inconvenient.
Highly distressful for the patient. Or only parts of it can remain open, forming an isolated urethral cyst along that tract. But the big pathology takeaway for board exams here is cancer.
How?
Because the urachus is lined by glandular epithelium, if you see an adenocarcinoma specifically located in the exact dome of the bladder, the very top part, you have to have a high clinical suspicion that it arose from a malignant transformation of a hidden urachal remnant.
Wow, okay. Let's move on to something incredibly common. Inflammation of the bladder. Cystitis. This is something so many people, especially women, are intimately familiar with.
Extremely common in clinical practice. The classic triad of symptoms you'll see are frequency, meaning feeling the need to go every 15 minutes, suprapubic pain, which is an aching or cramping right above the pubic bone, and dysuria, a sharp, painful burning sensation upon actual urination.
And who gets it and why? You mentioned women.
Women are at a much, much higher risk purely because of regional anatomy. Females have a significantly shorter urethra, which simply allows fecal bacteria from the perineum, like E. coli or Proteus species, to easily ascend into the sterile bladder.
But it's not strictly just bacterial causes, right? The text lists quite a few others.
No, absolutely not. You have viral causes, most notably adenovirus, which notoriously causes hemorrhagic cystitis, where the patient actually has, frankly, bloody urine. You also have parasitic causes, like schistosoma hematobium.
That's the blood fluke, right?
Yes, extremely common in the Middle East and parts of Africa, particularly Egypt. The parasite spiked eggs deposit directly into the bladder wall, causing massive chronic inflammation, granulomas, and dense fibrosis. And this is a major risk factor for developing squamous cell carcinoma of the bladder, a cancer type which is otherwise quite rare in the Western world.
And then there is the doctor-caused or iatrogenic cystitis.
Specifically from chemotherapy, cyclophosphamide is the absolute classic culprit here. It metabolizes in the body into a compound called acrolein, which is directly toxic to the delicate bladder lining, causing a severe hemorrhagic cystitis. Radiation therapy to the pelvic region for other cancers can severely damage the bladder mucosa, too.
Now, I want to unpack two very specific, unique types of cystitis that the Robbins text highlighted because they have very distinct testable pathology. First up, interstitial cystitis, which is also known as bladder pain syndrome.
This is a tremendously frustrating diagnosis for both the patient and the physician. It mostly affects women. They present with intense, debilitating suprapubic pain, severe frequency, and extreme urgency. It completely ruins their quality of life. But when you dutifully culture the urine, nothing. No bacteria at all. Absolutely sterile. It's largely a diagnosis of exclusion. But if a urologist looks inside with a cystoscope, they might see mucosal fissures or these tiny punctate bleeding spots we call glomerulations.
And what about in the late severe stages?
In late stages, you see these very specific lesions called Hunter ulcers, chronic mucosal ulcers, extending into the lamina propria. The chronic inflammation can eventually lead to a stiff, shrunken, fibrotic bladder that can barely hold any volume. It's a terrible mystery condition, really. The exact cause is still heavily debated.
The second special type of inflammation is malakoplakia. This one sounds like a mouthful, but the cellular pathology is totally fascinating.
Malakoplakia is a microscopic pathologist's absolute dream. It's fundamentally due to an acquired, specialized defect in phagocyte function.
Okay, let's break that down for the listener. Phagocytes are the immune cells that literally eat bacteria to clear infections.
Specifically, we're talking about macrophages here. In malakoplakia, the macrophages easily engulf the offending bacteria, usually a chronic E. coli infection, but then they completely fail to digest them.
Why?
Their internal lysosomes are somehow enzymatically defective. They can eat all day, but they can't degrade the bacterial cell walls. So the intact bacterial debris just massively piles up inside the cytoplasm of the cell.
And what does that physically look like, both grossly and under the microscope?
Grossly, if you look at the inside of the bladder wall, and Robbins has a great picture of this in figure 21.3a, you see these soft, yellow, slightly raised plaques scattered around. But the real money shot is under the microscope.
Right, the special cells.
Yes. The bloated, debris-stuffed macrophages are called von Hensemann histiocytes. And over time, calcium and iron salts actively precipitate and deposit directly onto this undigested bacterial material inside the cell. It forms these very distinct, laminated, mineralized concretions.
They look kind of like tiny targets, right? Or maybe owl eyes.
Exactly. They have a concentric, targetoid appearance. We call them Michaelis-Cutman bodies.
That sounds like a classic high-yield medical school exam question.
It absolutely is. I guarantee you, if a question stem describes Michaelis-Cutman bodies, or von Hensemann cells, the answer is malakoplakia. It's an automatic point.
Let's quickly touch on metaplastic lesions of the bladder before we hit cancer.
Sure. Metaplasia is just the tissue changing its cell type in response to stress. You have cystitis glandularis and cystica, where normal nests of urothelium called von Brunn nests dip down into the underlying connective tissue and biologically transform into cuboidal glands or fluid-filled cysts.
And squamous metaplasia.
That's just the normal transitional lining turning into tougher squamous skin cells in response to chronic injury, like a long-standing catheter or a stone rubbing against the wall. Then there's nephrogenic adenoma, which is really wild. It's actually shed renal tubular cells from the kidney that float down the urine stream and physically implant themselves into an injured spot on the bladder wall.
That's incredible, just grafting themselves right on there. Okay, let's move to the heavyweight topic. Neoplasms of the bladder. Bladder cancer.
This is a massive topic. The vast majority of these, about 90%, are urothelial carcinomas arising straight from the transitional epithelial lining.
What are the main risk factors we need to know?
Smoking. Cigarette smoking is the big one. It increases the risk anywhere from 3 to 7-fold. The specific carcinogens from the tobacco, notably things like nephylamine, are actively excreted by the kidneys into the urine, so they just sit there pooling in the bladder, physically bathing the delicate lining in toxins for hours between trips to the bathroom.
So it's essentially a prolonged contact poison.
Exactly. Other risks include industrial air lemon dyes, historically seen in textile or rubber workers, schistosoma infection, as we discussed, and long-term heavy use of certain analgesics.
And now the text meticulously outlines two completely distinct precursor molecular pathways for developing bladder cancer. This seems like a really crucial concept to grasp.
It is fundamental to understanding the disease. You have the papillary pathway and you have the flat pathway. They look different, they have different genetics, and they behave differently.
Let's take the papillary pathway first. What does that look like?
Imagine a tiny, delicate fern or a sea anemone growing out of the flat lining into the open space of the bladder. It starts off as simple hyperplasia, just too many cells, which then develops into a low-grade, non-invasive papillary tumor. The primary genetic drivers here are very often gain-of-function mutations in the FGFR3 or RAS oncogenes.
So these are mutations that basically lock the growth switch in the on-ends position.
Yes. They relentlessly tell the cell to divide. These specific tumors are annoying because they frequently recur after the surgeon scrapes them out, but they're generally less aggressive initially. Because they grow outwards, exophytically, into the open lumen, they don't immediately dive down into the deep tissue.
And what about the flat pathway?
This is the hidden dangerous one. It starts as flat carcinoma in situ, or CIS. Grossly, if you're looking with the camera like in figure 21.8, the surface just looks like flat red, slightly granular patches. There is no actual mass or tumor sticking out. It's completely flat.
But the individual cells themselves?
Under the microscope, the cells are frankly malignant. They are high-grade, very ugly anaplastic cells right from the start. The genetic drivers here are typically early loss-of-function mutations in TP53 and RB, which are the crucial tumor suppressor genes. The brakes are completely removed.
So even though it's technically flat and quote-unquote in situ, meaning it hasn't physically invaded the deep tissue yet, it is biologically a highly aggressive beast.
Extremely. We even see this phenomenon called pagetoid spread, where scattered individual malignant cells creep along and hide within the otherwise normal-looking urothelium. Because it's already a high-grade mutation profile, when CIS finally does breach the basement membrane and invade, it tends to go deep and it spreads fast.
Speaking of invasion, let's talk about staging. The book makes it clear that staging is what ultimately determines if a patient lives or dies.
Correct. Grading is how ugly the cells look, but staging is how far they physically traveled. We primarily use the T-staging system.
Walk us through the important thresholds.
Sure. Ta, which are those non-invasive papillary tumors, and Ts, which is the flat CIS, are confined to the top surface. They're highly treatable. T1 means the cancer has dropped down and invaded the lamina propria, the loose connective tissue right under the lining. But the absolutely critical, life-altering threshold is T2.
T2 is defined as invasion into the muscularis propria,
the thick detrusor muscle itself. Once the cancer cells have access to that deep muscle layer, the mortality rate jumps significantly because they now have easy access to rich blood vessels and lymphatics. That is the definitive line in the sand for aggressive surgical treatment, which usually requires completely removing the entire bladder, a radical cystectomy.
Before we officially leave the bladder, just briefly mention the other rarer cancer types.
Right. We have squamous cell carcinoma, again, heavily linked to the chronic inflammation of schistosomiasis, primarily in endemic regions like Egypt, and adenocarcinoma, which is quite rare, but usually arises from those congenital urachal remnants at the bladder dome, or from areas of extensive intestinal metaplasia.
Okay, descending further down the anatomical tree, the urethra.
The final exit pipe, it gets inflamed quite easily. Urethritis.
And this is usually sexually transmitted, right?
Very often. We clinically divide it into gonococcal urethritis, obviously caused by Neisseria gonorrhea, and non-gonococcal urethritis.
And the non-gonococcal culprits are usually...
Chlamydia trachomatis is the most common, followed by various mycoplasma species.
There's a specific syndrome mentioned here that ties back to joint and eye pathology reactive arthritis, which I think was formerly known as Reiter syndrome.
Yes, it presents with the classic triad: arthritis, conjunctivitis, and urethritis. The old medical school mnemonic is can't see, can't pee, can't climb a tree. It's actually a systemic autoimmune cross-reaction triggered by the initial urethral or GI infection.
And for actual tumors of the urethra?
True carcinomas are extremely rare. You can see fungating masses like in figure 21.11, usually squamous cell. But the most clinically notable lesion to remember is the urethral caruncle.
What's that?
This presents as a small, exquisitely painful, bright red mass right at the external urethral meatus, almost exclusively in older postmenopausal females. It is strictly an inflammatory lesion, not a true cancer, but it's a highly friable, meaning it bleeds very easily when touched. It can look terrifyingly like a cancer to the patient, but it's completely benign and easily excised.
Okay, we are now leaving the urinary tract proper and crossing over to the male genital system. Let's talk about the penis.
Starting again with congenital anomalies, hypospadias and epispadias.
These are malformations regarding exactly where the urethral opening sits, correct?
Instead of the urethral opening cleanly at the very tip of the gland's penis, it opens somewhere else along the shaft. In hypospadias, the opening is located somewhere on the ventral surface, the underside of the penis. This is by far the more common one, happening in roughly 1 in every 300 male births.
And epispadias?
Epispadias is when the opening is on the dorsal surface, the top of the penis. This is much rarer, and as we touched on earlier, it's very frequently associated with that severe bladder exstrophy defect.
Why do these defects matter medically, aside from the obvious cosmetic and psychological impacts?
They cause abnormal urinary streams, which can lead to obstruction and an increased risk of ascending urinary tract infections. Also, if the abnormal opening is located far down near the base of the penis, it can directly cause sterility simply because normal intravaginal insemination is physically hampered.
Another common clinical term here, phimosis.
Phimosis is a condition where the anatomical orifice of the prepuce, the foreskin, is too tight and small to be pulled back or retracted over the glands. It can sometimes be a primary developmental issue, but far more often, it's an acquired stricture due to dense scarring from repeated localized infections.
And the main problem there is hygiene, right?
Exactly. When you can't retract it, normal desquamated skin cells and secretions accumulate underneath, forming a substance called smegma. This trapped smegma and bacteria cause chronic smoldering inflammation, and that chronic irritation significantly increases the long-term risk of developing penile carcinoma.
Speaking of that localized inflammation, let's formally define balanoposthitis.
That's simply the medical term for infection and inflammation of both the glans penis and the overlying prepuce. It's usually caused by poor local hygiene in uncircumcised males, with that smegma acting as a severe local irritant for fungal or bacterial overgrowth.
Now let's discuss tumors of the penis. We have to talk about HPV.
Human papillomavirus. It's a primary driver for the benign superficial tumors here, specifically condyloma acuminatum, more commonly known as genital warts. These are strongly caused by the low-risk HPV viral types, specifically types 6 and 11.
Visualizing figure 21.2 all from the text.
They visually present as these branching exophytic cauliflower-like masses, usually on the coronal sulcus or inner prepuce. But again, the definitive diagnosis comes under the microscope. The absolutely key defining histologic feature is coilocytosis.
Walk us through what coilocytosis actually is.
It is the absolute cellular hallmark of an active HPV infection. When you look at the squamous epithelial cells, they have this very distinct, dark, wrinkled raisinoid nucleus, and that nucleus is surrounded by a large, sharply defined, clear halo of perinuclear vacuolization. If you see coilocytes on a slide, you definitively have HPV cytopathic effect.
What about non-HPV conditions like Peyronie disease?
Peyronie disease is a non-neoplastic fibromatosis. Essentially, asymmetrical, dense, fibrous bands of collagen abnormally deposit in the connective tissue sheaths of the corpus cavernosum. When the penis becomes erect, these rigid, non-stretchy bands cause painful, severe curvature of the shaft.
Okay, let's talk about the malignant tumors. Squamous cell carcinoma of the penis.
Epidemiologically, this is very rare in the United States, accounting for less than 1% of male cancers. But geographically, it's a huge issue elsewhere. It can account for up to 10 to 20% of male malignancies in parts of Asia, Africa, and South America.
And the text makes a very specific point about circumcision here.
Yes, routine neonatal circumcision acts as a massive protective factor. It removes the anatomical environment that traps smegma, vastly improves hygiene, and significantly reduces the accumulation of high-risk HPV strains. The cancer is virtually unheard of in males circumcised early in life.
And what do the precursor lesions to this cancer look like?
We group them under the umbrella term penile intraepithelial neoplasia, or PI. If the lesion is heavily associated with high-risk HPV, usually type 16, it clinically presents in two main ways. First is Bowen disease, which usually looks like a single solitary thickened gray-white or red plaque on the shaft of older men.
And the second?
Bonoid papulosis, which presents as multiple pigmented reddish-brown papules, usually in much younger sexually active men.
Do they both turn into cancer?
Interestingly, no. Bonoid papulosis actually often regresses completely on its own over time. Bowen disease, however, is a true in situ carcinoma and has a significant risk of progressing to frankly invasive squamous cell cancer if left untreated.
Let's move higher up into the scrotum, the testis and epididymis.
Okay, first up on the list, cryptorchidism, the completely undescended testes.
Normally, during fetal development, the testes is supposed to migrate from its origin high up in the abdomen, down through the inguinal canal, and finally rest in the scrotal sac.
Correct. If it gets stuck anywhere along that specific pathway, and it's usually arrested right in the inguinal canal itself, that is clinically defined as cryptorchidism. It's actually a fairly common defect, happening in about 1% of all 1-year-old boys.
So what physically happens to the testicular tissue if it stays trapped up inside the body?
It essentially cooks. The core body temperature is simply too high for delicate testicular tissue. If you look at the morphology in figure 21.15, you see severe regressive changes. The seminiferous tubules become completely atrophic, the delicate basement membranes become heavily thickened with collagen, and the vital germ cells, the spermatogonia, just die off.
Meanwhile, the Leydig cells seem to multiply.
They appear to, yes. You get this prominent, apparent Leydig cell hyperplasia, mostly because the tubules have shrunken so much that the Leydig cells in the stroma look artificially concentrated.
So profound infertility is obviously the main result.
Infertility is a massive risk, especially if it's bilateral. But the darker, more dangerous clinical risk is cancer. There is a verified 3 to 5-fold increased risk of developing a primary testicular germ cell cancer in cryptorchid testes. And here is the absolute kicker. The cancer risk is statistically increased, even in the normally descended, completely opposite contralateral testes.
Wow. So that strongly suggests it's not strictly just the high temperature causing the cancer, right? It implies an underlying intrinsic genetic defect in the germ cells themselves?
Exactly. The thermal damage certainly destroys the sperm, but the cancer risk is likely a developmental field defect. Performing early surgical correction and orchiopexy, pulling it down at the scrotum before age 2, it helps preserve remaining fertility, and crucially, it makes any future cancer much easier to detect on a physical exam. But it doesn't completely eliminate that inherent genetic cancer risk.
Before we get deep into the tumors, let's touch on a true urologic emergency: torsion.
Testicular torsion. This is a nightmare scenario where the entire spermatic cord twists on its axis, completely cutting off the blood supply. But the specific mechanical sequence of how it happens is very important. It always cuts off the thinner, easily compressible venous drainage system first.
But the thick-walled arteries manage to stay open.
For a brief window, yes. The thick-walled, high-pressure arteries keep violently pumping arterial blood into the testes, but the twisted, thin-walled veins are completely pinched shut. So the blood goes in, but it can't get out. The testes rapidly engorges with trapped blood. Eventually, the internal tissue pressure builds up so immensely high that it physically compresses and stops the arterial inflow as well. This leads to a massive, painful hemorrhagic infarction.
Figure 21.72 shows a torse testicle that looks, well, it's pitch black and swollen.
It is massively necrotic and hemorrhagic. It's totally dead tissue. If you don't aggressively surgically untwist it, manually restoring the flow within about 6 hours of the onset of pain, the entire testis is permanently lost. This is exactly why sudden, severe testicular pain in a young man is a drop everything and go to the ORI emergency.
Moving on to inflammation. Epididymitis versus orchitis.
Generally speaking, inflammatory infections down there almost always start in the epididymitis, and then they physically spread inward to involve the testes itself, which is orchitis.
And the bacterial cause depends almost entirely on the age of the patient.
This is a golden classic medical school rule. If the symptomatic male patient is under 35 years old, you must immediately think sexually transmitted pathogens, specifically chlamydia trachomatis or Neisseria gonorrhea. If the patient is over 35, you shift your thinking to common urinary tract pathogens that cause UTIs, like E. coli or Pseudomonas.
There's also a specific non-infectious entity called granulomatous orchitis.
Yes, also known as autoimmune orchitis. It typically presents in middle-aged men as a relatively painless, progressively enlarging mass. It's incredibly important because it clinically totally mimics a testicular cancer. But under the microscope, it's just non-case-eating granulomas strictly confined within the borders of the seminiferous tubules.
And there are a few very specific systemic infections mentioned that love the testes. Mumps.
Mumps is a virus that absolutely loves glandular tissue. It attacks the parotid salivary glands in the face, but it also aggressively attacks the testes. If a postpubertal male gets mumps, the resulting mumps orchitis can be incredibly severe and can absolutely result in permanent sterility.
And tuberculosis.
TB always starts in the epididymis first and causes classic caseating granulomas, that cheesy necrotic inflammation.
And syphilis.
Syphilis is the weird outlier. Unlike TB or gonorrhea, treponema pallidum tends to actually hit the testes first, often completely sparing the epididymis initially. Histologically, you might see massive gummas, those large, rubbery necrotic granulomas, or severe obliterative endarteritis with lots of plasma cells.
Okay, now we arrive at a truly massive and complex topic. Testicular tumors.
Right. It's critical because this is the single most common solid tumor malignancy in young men aged 15 to 34.
And an overwhelming 95% of them are germ cell tumors, or GCTs.
Exactly. They arise directly from the reproductive germ cells.
Yeah.
And clinically, we divide all GCTs into two big overarching buckets, seminomas and non-seminomatous GCTs.
Why do we make that specific split?
Because the medical treatment and the ultimate prognosis are completely different between the two. Pure seminomas are remarkably sensitive to radiation therapy and generally have a fantastic prognosis, even if they've spread to lymph nodes. Non-seminomas are biologically much more aggressive, they spread early, and they heavily require systemic platinum-based chemotherapy.
Let's walk through the specific types, starting with the seminoma.
This is the most common pure type, making up about 50% of cases. If you look at the gross pathology in figure 21.20, it's this very uniform, homogeneous, bulging, gray-white lobulated mass. It looks remarkably clean. There's typically no hemorrhage, no gross necrosis.
And what does it look like under the microscope?
Figure 21.21 shows this beautifully. You see monotonous sheets of uniform cells that uniquely look like fried eggs. They have a prominent, dark central nucleus surrounded by abundant, very clear cytoplasm. And the delicate fibrosepta that divide these cells almost always contain a heavy infiltrate of normal lymphocytes. That inflammatory response is a key diagnostic feature.
And what about serum tumor markers for seminoma?
About 10% of patients might have a mildly elevated HCG, but AFP alpha-fetoprotein is absolutely never elevated in a pure seminoma. If the AFP is high, it's not a pure seminoma, end of story.
Now let's jump into the non-seminomatous group, starting with embryonal carcinoma.
This is the ugly, aggressive one. Look at figure 21.22. Grossly, unlike the clean seminoma, the embryonal mass is highly variegated, visibly hemorrhagic, and full of soft necrotic tissue. The cells themselves are wildly primitive and highly anaplastic, forming messy, disorganized sheets or poorly formed primitive glands. It's a very aggressive, deeply invasive cancer. It frequently secretes both HCG and AFP.
Next is the yolk sac tumor.
This is a unique one because it is the most common primary testicular tumor in infants and young children up to about 3 years old. And remarkably, in that specific young age group, the prognosis is actually exceptionally good.
What's the specific tumor marker for yolk sac?
AFT. Alpha-fetoprotein is sky high. If you have any patient with a testicular mass and a significantly elevated AFP, you have to think there are yolk sac elements present.
And the microscopic hallmark.
Histologically, you look for these specific structures called Schiller-Duval bodies. They visually resemble primitive kidney glomeruli, essentially a central blood vessel surrounded by a layer of tumor cells.
Next, we have choriocarcinoma.
This is unequivocally the worst, most highly malignant of the entire bunch. It's essentially a cancer mimicking early placental tissue. It's composed strictly of two cell types growing together: small polygonal cytotrophoblasts and massive multinucleated syncytiotrophoblasts.
And those syncytiotrophoblasts produce something specific, right?
Yes, they heavily secrete human chorionic gonadotropin HCG. You will see sky-high HCG levels. The really terrifying behavior of choriocarcinoma is that it aggressively invades blood vessels very early on. It rapidly spreads hematogenously directly to the lungs and the brain. Sometimes the primary tumor in the testes is so small it's impalpable, or it's even completely burned out and turned to scar tissue. But the patient abruptly presents in the ER with hemoptysis, coughing up blood from massive metastatic lung lesions.
Finally, for the germ cells, we have the teratoma.
The literal monster tumor. It contains completely differentiated cellular elements derived from multiple different embryonic germ layers. If you cut into one, you might find fully formed skin, hair follicles, disorganized teeth, Islands of cartilage, mature thyroid tissue, or even bits of neural brain tissue, all chaotically mixed up into a solid, disorganized mass.
Is a teratoma considered benign or malignant?
It totally depends on the patient's age. It's a strict rule of thumb. In prepubertal children, teratomas are almost always totally benign. But in postpubertal adult males, any teratoma is inherently considered to have malignant metastatic potential, regardless of how mature or benign the individual tissues inside it look.
So just to heavily recap those crucial serum markers, pure seminoma might have some HCG but never AFP, UXAC is exclusively AFP, choriocarcinoma is exclusively HCG, and embryonal can be both.
It's exactly right. And it's incredibly important to note that mixed germ cell tumors, where a single tumor literally contains a chaotic mix of seminoma, embryonal, teratoma all jumbled together, are actually the most common clinical presentation, making up about 60% of all cases. You treat based on the most aggressive component present.
Before we leave the testes, what about tumors that aren't from germ cells? The sex cord gonadal stromal tumors.
These are rare, arising from the supporting stromal cells. The Leydig cell tumor is fascinating because it's actively functional. It produces potent hormones. In children, it pumps out androgens, causing sudden precocious puberty. In adults, it might produce estrogens, causing gynecomastia.
And the microscopic feature there.
They often contain these unique rod-shaped cytoplasmic inclusions called Reinke crystals. Then you have the Sertoli cell tumor, which is generally hormonally silent and presents as a benign, homogeneous, firm, yellow-gray nodule.
We have one final major stop on this anatomic tour, the prostate.
The prostate gland. A tiny walnut-sized organ that undeniably causes more misery and trouble than perhaps any other single organ in the aging male body.
Let's talk about the real estate first, the internal anatomy, the specific zones.
This is absolutely crucial to understand the pathology. The prostate is divided into distinct biological zones. The transition zone is the inner area that immediately surrounds the urethra. This specific zone is the exclusive site of benign prostatic hyperplasia, or BPH.
Okay, and the outer layer.
That's the peripheral zone. It's the large outer shell at the back of the gland. This zone is the primary site where invasive carcinoma arises.
And that anatomical setup completely explains the clinical presentations, doesn't it? EPH happens right around the urethra, so it immediately causes urinary obstruction symptoms. But cancer happens on the outside edge, which is why a doctor can physically feel a hard cancer nodule during a routine digital rectal exam right through the rectal wall.
Precisely. The location dictates the symptom. BPH squeezes the pipe. Cancer hides quietly on the periphery until it's quite large.
Let's hit prostate inflammation first. Prostatitis.
Acute bacterial prostatitis is very straightforward. It's usually a nasty E. coli infection. The patient is acutely ill with high fever, severe chills, and exquisite dysuria. If you examine them, the prostate is incredibly tender, swollen, and feels boggy to the touch. You actually have to be careful not to massage it too hard or you throw them into septic shock.
And chronic bacterial prostatitis.
That presents as subtle, recurrent urinary tract infections with the exact same organism over and over. The bacteria hide deep inside the prostatic acina, and most normal antibiotics penetrate the prostate tissue very poorly, making it incredibly hard to permanently eradicate.
The text also emphasizes chronic abacterial prostatitis.
Yes, formerly called chronic pelvic pain syndrome. It is incredibly frustrating because it is actually the most common form by far. The patient has intense localized pain and discomfort, but extensive cultures repeatedly show absolutely zero bacteria. It's an inflammatory condition of unknown etiology, and it's notoriously difficult to treat effectively.
Now let's dive into benign prostatic hyperplasia, BPH.
This is essentially ubiquitous. It's so extremely common in aging men that it's almost considered a normal part of getting older. It is entirely driven by hormones, specifically potent androgens.
The main culprit is DHT, right?
Yes, dihydrotestosterone, or DHT. It's a very potent local androgen that is converted directly from circulating testosterone right inside the prostate cells by an enzyme called 5-alpha reductase.
So what does the DHT actually do?
It acts as a powerful growth factor. It aggressively drives both the stromal connective tissue cells and the luminal glandular epithelial cells to relentlessly proliferate.
And physically, this results in nodules. Figure 21.3 shows this very clearly.
Right. The prostate becomes massively enlarged and grossly nodular. And depending on the patient, these inner nodules can be mostly solid stromal tissue, which feels very firm and rubbery, or they can be mostly overgrown glandular tissue, which is softer and more spongy.
And because this is happening in that central transition zone,
it mechanically compresses the urethra from all sides, turning it from a nice wide tube into a tiny squished slit.
leading to those classic obstruction symptoms.
Exactly. Hesitancy starting the stream, severe dribbling at the end, and a constant feeling of urinary retention. It's a purely mechanical plumbing block. And as we discussed at the very beginning of this deep dive, that increased back pressure can progressively hypertrophy the bladder, cause diverticula, and eventually back up to damage the kidneys.
Finally, the big one, adenocarcinoma of the prostate.
Epidemiologically, this is the single most common form of visceral cancer in men, period.
What drives its pathogenesis?
It's multifactorial. Androgens are absolutely required. Castrated males do not get prostate cancer. Heredity plays a massive role. Men with specific germline mutations in genes like BRCA2 and HOSB13 have a drastically elevated risk. And environment matters too. Westernized diets high in fats seem to strongly promote progression.
Let's look closely at the morphology. What are we seeing?
Grossly, when you cut into it, prostate cancer tissue is distinctly gritty, firm, and usually yellow-white, completely lacking the spongy, bulging appearance of benign BPH nodules. It's poorly demarcated. It just infiltrates into the surrounding normal tissue.
And under the microscope?
Microscopically, you see an unorganized proliferation of small, very crowded back-to-back glands.
Now, what is the absolute key cellular feature that confidently tells a pathologist this is an invasive cancer and not just a weirdly crowded benign gland?
It is the complete absence of the basal cell layer.
Explain that.
Normal, healthy prostate glands always have a distinct two-layer architecture. A tall interluminal secretory layer resting on top of a continuous flat basal cell layer right on the basement membrane. Invasive prostate cancer completely loses that bottom basal layer. The malignant glands are strictly composed of only a single uniform layer of cells with prominent dark nucleoli. If the basal cells are gone, it's cancer.
And when a pathologist diagnoses it, they grade it using the famous Gleason system.
Yes. The Gleason score is completely unique in oncology. It is based entirely on the low-power architectural pattern of the glands, not on how ugly the individual cells look cytologically. It's purely about how the glands are structurally organized in space.
Figure 21.36 diagrams this beautifully. Walk us through the grades.
So grade 3 tumors form discrete, well-formed, clearly separated individual glands. It's like a neatly planned suburban neighborhood. Grade 4 tumors are more advanced. The glands are actively fusing together into large, messy sheets or forming a cribriform pattern which looks exactly like a piece of Swiss cheese with holes punched in it.
In grade 5.
Grade 5 is total architectural anarchy. There are essentially no recognizable glands left at all. The tumor cells are just invading as solid sheets or disorganized single-file cords through the stroma.
And the final score is an addition problem, right?
Correct. Because prostate cancer is notoriously heterogeneous, meaning it has different patterns in different areas of the same tumor. The pathologist identifies the most common pattern and then adds it to the second most common pattern.
So a 4 plus 3 equals 7 is actually considered much worse than a 3 plus 4 equals 7.
Yes, entirely, because the highly aggressive grade 4 pattern is physically the dominant volume of the tumor in the first scenario. We now further group these scores into modern grade groups 1 through 5, which correlate much better with actual patient prognosis and survival.
Where does advanced prostate cancer tend to spread?
Locally, it directly invades through the prostatic capsule into the nearby seminal vesicles or the base of the bladder. Lymphatic spread typically hits the local obturator and iliac pelvic lymph nodes first.
But the hematogenous spread, the blood spread, has a very specific favorite target.
Yes. It absolutely loves to metastasize to the axial skeleton, the lumbar spine, the pelvis, the ribs. And unlike most other metastatic cancers, like lung or breast cancer, which are typically lytic and literally eat or dissolve holes in the bone, prostate cancer bone metastases are highly osteoblastic.
Meaning they force the bone to build more bone.
Exactly. They secrete factors that overstimulate the patient's osteoblasts to lay down dense, abnormal, new woven bone. So if you see an older man with new back pain and his x-ray shows these distinctly dense, bright, white, sclerotic ivory spots on his vertebrae, it is metastatic prostate cancer until definitively proven otherwise.
Let's briefly touch on PSA screening before we wrap up. Prostate-specific antigen.
PSA is a heavily utilized but highly controversial screening tool. It's a protease normally secreted by the prostate into the seminal fluid to help liquefy semen, but tiny amounts leak into the blood.
So a high blood PSA means cancer?
Not necessarily, and that's the massive clinical problem. PSA is strictly organ-specific, not cancer-specific. Anything that irritates the prostate makes the PSA leak into the blood. So a massive benign BPH gland vastly raises the PSA. A painful bout of bacterial prostatitis drastically spikes the PSA. And yes, a tiny microscopic cancer also raises the PSA.
So it lacks specificity.
Exactly. It generates a massive amount of false positives, leading to potentially unnecessary invasive biopsies, which carry real risks of infection and bleeding. It is a very useful tool for tracking a patient's response to therapy after they've already been diagnosed. But as a broad population screening tool, it requires very careful, nuanced discussion between the doctor and the patient.
Wow. Okay. Let's really take a second to unpack exactly what we just rapidly covered. We followed the flow. We went from the rigid king toes of the pediatric UPJ obstruction down through the terrifying, strangling straitjacket of retroperitoneal fibrosis.
We examined the stagnant potholes of bladder diverticula, the fascinating fried egg cells of the highly curable seminoma, and the massive hemorrhagic destruction of a torsed testes.
And we finally ended down with the benign, squeezing nodules of BPH and the dangerous, gritty, invasive glands of prostate cancer.
What consistently stands out to me across all of this is just how violently mechanical these diverse pathologies are. A simple developmental twist, an external fibrous block, an internal cellular compression. It really beautifully highlights how macroscopic form and microscopic function are utterly fundamentally inseparable.
And for you, the listener, whether you are clinically diagnosing these conditions on the wards, desperately cramming them for your board exams tonight, or just living life managing the realities of your own plumbing, understanding the why behind the symptoms really makes all the difference in the world.
Absolutely it does. The why is always the key to the what.
Well, here's a final provocative thought for you to mull over as you close your books today. We spent all this time talking about how the pelvic anatomy is dangerously crowded and how a physical obstruction in one single tube, like a ureter or a urethra, mechanically destroys the organs upstream. But consider this. What if the actual evolutionary trade-off for having such a highly compacted, neurologically dense, and intensely complex reproductive and voiding system is precisely this extreme vulnerability to pressure? What if the very structural design that allows for complex human reproduction is fundamentally, structurally incompatible with long-term, flawless mechanical longevity? Just something to think about the next time you turn on a faucet.
That's a profound way to look at it. Good luck with your studies, everyone. Keep grinding.
Thanks for listening to this last-minute lecture. Have a great day.